Let's now talk about a very interesting topic, that is thermal injuries. Thermal injuries is important from the point of view of the exam, but also a very common thing which you encounter in clinical practice. So I feel all MBBS graduates should know the basics of burns management. So that's what we are going to talk about here. Of course, the first question which we need to answer is which patients need to be referred to a specialized burn center, right? And this MCQ has been asked in various exams. So these are the American Burn Association criteria to refer a patient to a specialized burn center. So you need to know some of these criteria for the exam. The first one is a patient who has any burns and concomitant trauma like fractures, burns in children, burns in patients who require special social or emotional support. Then if there are burns in patients with pre-existing medical conditions. Very important for the exam are burns that are involving the face, hand, feet, genitalia, perineum or major joints. This is a very important point which you need to know for the exam. Any chemical burns, any electrical burns, any inhalational injury if it is present. And these two are the ones which have been asked most frequently in the exam. Any partial thickness burns more than 10% body surface area, or any full thickness, that is 3rd degree or 4th degree burns, right? So partial thickness burns more than 10%, or any full thickness burns in any age group. These two are also criteria to refer a patient to a specialized burn center. Now, when these patients reach the specialized burn center and you are the doctor who are treating them, what are the things which you will look at? So, as we discussed in trauma we spoke about airway, breathing and circulation. The additional things here are D and E. D we spoke about in trauma, also disability. E is exposure. Exposure in burns patient tells us what was the cause of burns and what is the extent of burns. So in any burns patient who comes to the burns center, what we look at is A, B, C, D. This we discuss in the basics of burns management. That is airway, breathing, circulation, disability. The additional thing in burns patients which is very important is exposure, and that takes into account what was the cause of burns and what are the extent of burns. These are two very important questions which we need to answer in all burns patients. So the first thing which is most important is airway, and we need to rule out inhalational injury, right? In airway, what is important is we need to rule out inhalational injury, and you should know the danger signs of inhalational injury or airway burns. These danger signs are burnt or singed nasal hair. This is the most sensitive sign and the one which you should really look out for, burnt or singed nasal hair. Then if you have burns in a closed room, burns involving the face and the neck, if there are carbonaceous deposits in the sputum, if there's hoarseness of voice and altered mental sensorium, these are the points which you need to remember. And if any of these points are there, we suspect that there are airway burns. And if we suspect airway burns, then we should carry out prophylactic intubation in these patients. And the reason for this prophylactic intubation is because the burn tissue, the laryngeal tissue will swell up immediately. And when it swells up immediately, it will not give you time to secure an airway at that time. That is why you need to preemptively anticipate that these patients can land up with airway obstruction. So if any of these danger signs are present, it is better to prophylactically intubate that patient. In the latest submission, there is one more indication which is mentioned, that if burned area is more than 40% total body surface area, if burned area is more than 40% total body surface area, then also we should carry out a prophylactic intubation in these patients. Now, if there are airway burns will proceed in 3 stages. And the first stage of airway burns is acute pulmonary insufficiency, where the patient will come with breathlessness and there will be a reduced saturation of oxygen which can be seen in this initial phase. Phase 2 which is seen after 48 to 72 hours later, and this is the phase of ARDS-like picture, where you can have bilateral infiltrates in the lung, where there can be bilateral infiltrates in the lung and there can be hypoxia as well. And finally, what happens is that there can be bronchopneumonia. Pneumonia can set in. And why does pneumonia occur? A, because of the injury to that epithelium or mucosa, and B, because burns causes a global decline in immune function, right? So burns also decrease the immune response of the body. So there can be bronchopneumonia. And you need to know in the early phase, that is 1 to 3 days, this bronchopneumonia is mainly due to staph. It is staphylococcal pneumonia. But in the later stages, after 3 days, this can be gram-negative. This can be gram-negative bronchopneumonia which can develop in these patients, and it needs to be treated accordingly with antibiotics. And also there is a role of bronchodilators. So to nebulize the patient with bronchodilators, there is a role in patients with airway burns. The second aspect is we need to look at breathing. So what are the aspects which we need to look at breathing? Breathing, we need to look at hypoxia, which I told you can occur because of airway burns. Second, because of inhalation of all these toxic compounds, there can be carbon monoxide poisoning. And you have discussed in forensic in detail what are the features of carbon monoxide poisoning. You should be on the lookout for those signs and symptoms of carbon monoxide poisoning in burns patients as well. And third is the presence of eschar around the chest wall. So what is eschar? Eschar is thickened tissue after burns. This is thickened tissue, and this restricts the lung expansion. This restricts the chest expansion, right? So if this thickened tissue is present around the chest, the patient cannot breathe properly. So that is why we will discuss later that if there is eschar around the chest, then an escharotomy needs to be done. In these patients. This I'll talk about later in detail. Circulation is also a very important aspect in burns patients. And what happens is that there is an inflammatory response. There is an inflammatory response to burns. And this is directly proportional to the extent of burns. This is directly proportional to the extent of burns, right? If small area is burnt, that means less than 10% total body surface area. TBSA is total body surface area. Then this is a localized response. Then this inflammatory response is a localized response. But if more than 10% total body surface area is involved, then this can give rise to a generalized response as well. So even though the burns might be restricted to the arm and some portion of the chest, but the changes would be seen in the entire body. So this can be a generalized response. And what happens is that when burns occur, these inflammatory mediators are released. These inflammatory mediators are released. And when these inflammatory mediators are released, what they are going to do is they will cause vasodilation. And when there is vasodilation, two things happen. One is there is increased evaporation. And the second is that there are leaky vessels or leaky capillaries which are there. Because of these inflammatory mediators, you have leaky capillaries. So these capillaries are going to leak out the large molecules. And what are the large molecules? These large molecules are albumin. And this albumin will go into the extravascular space. Now, we've discussed in physiology the laws which govern water movement. If you have albumin in the extravascular space, it is going to exert its oncotic effect and it will draw out fluid from the capillaries. And this gives rise to third space loss seen in burns. This adds to the third space loss seen in Burns patients where the fluid comes out into the extravascular space. So because of increased evaporation and because of third space loss, Burns patients are usually dehydrated. These are the reasons why Burns patients are dehydrated and they require proper fluid therapy. And there are two values which you should know. So more than 10% burns in a child and more than 15% burns in an adult can give rise to hypovolemic shock. One more point which I want you to remember here, which is very important, is that these leaky capillaries, this leakiness of the capillaries will last for 12 to 24 hours. It lasts for 12 to 24 hours. So what is the significance of knowing this point that this leakiness lasts for 12 to 24 hours? Well, the significance is that supposing I give colloids, you know, albumin is also a colloid, so that can also be used for resuscitation. Now, supposing I give albumin to this patient, because of these leaky capillaries, all the albumin will come out and it will draw more fluid out. So we might think that this albumin is helping the patient, but in reality it is being counterproductive because when the albumin comes out, it will draw out more fluid as well, right? And there'll be more third space loss. So therefore, the thing which I want you to remember, therefore no colloid resuscitation. There should be no colloid resuscitation in the first 12 to 24 hours after burns. There should be no colloid resuscitation in the first 12 to 24 hours after burns. Otherwise, it can be counterproductive like I've just explained to you. Now, these patients are dehydrated. So in these dehydrated patients, we need to give them fluids. We need to replace fluids. Now, if there are small areas of burns, then we can give oral liquids. But these oral liquids should contain salt. Otherwise the patient is going to have salt wasting. Otherwise they'll have salt wasting. Now, if there are more than 10 to 15% total body surface area burns are there, then these patients require IV fluids. And how do we calculate the IV fluids which are to be given in these patients? Well, the most commonly used formula is the Parkland's formula. And this has been asked multiple times in the exam. This is the Parkland's formula, which has been asked many times in the exam. Now, the update in the Parkland's formula you really need to remember. So, the old Parkland's formula was 4 into body weight into total body surface area. This is body weight in kgs and this is total body surface area. But the new Parkland's formula is 2 into body weight into total body surface area burnt. Right, so this is the new formula and this is in line with more judicious fluid therapy. If you remember the module on basics of trauma management and if you remember the module on shock, I've told you that now we are restricting the amount of crystalloids which we give to the patient, or the initial resuscitation amount we are restricting because giving too much can also be counterproductive. So that is why in a trauma patient, instead of 2 liters of crystalloid, we were giving 1 liter of bolus instead. Similarly, in burns patients, earlier it was 4 into body weight, now it is 2 into body weight, right? So please remember this. This is extremely important for the exam. So 2 into body weight into total body surface area burned. This gives us the amount of fluid in first 24 hours. This gives us amount of fluid in first 24 hours in milliliters. And this fluid, half of this fluid is given in the first 8 hours after burns. And the next half is given in the next 16 hours after burns. So these are also points which you should remember. First half in the first 8 hours, next half in the next 16 hours. And how do we monitor whether the adequate fluids are being given? We monitor that using urine output, right? So we'll see if the urine output is adequate or not. If the urine output is less, we need to give more fluids. So this is for Parkland's formula. This is a crystalloid based formula, which is the most commonly used formula. And this is for Ringer lactate, RL, or Hartmann solution. I've already told you the composition of Ringer lactate or Hartmann solution in the nutrition module towards the end. I've discussed about these fluids. Now, Parkland's formula, a lot of practical application questions have been asked in the exam as well. And I just want to give you a couple of examples so that this formula is absolutely clear to you. Before I give you those examples, I want you to know that this body weight is in kgs and total body surface area burned. First degree burns are excluded. First degree burns are excluded from this calculation. So if somebody has first degree burns, we are not going to take that into account. So let's consider an example here. We have a 60 kg man, and this 60 kg man commits a cardinal sin of forgetting his wedding anniversary date, right? So he's forgotten his wedding anniversary date and he's reached home. The wife is livid with this guy and she throws hot water at him. So the poor guy sustains 10% first degree, 10% second degree, and 10% third degree burns, right? What is the amount of fluid required by this patient in the first 24 hours, right? So now it will be 2 into body weight, which is 60, into total body surface area. Total body surface area, I told you, first degree burns are not included, they are excluded. So it is only going to be 20%. So 2 into 60 into 20 is the amount of fluid required by this patient in the first 24 hours. Now let's practice one more question. This 60 kg man did not learn from his mistake and next year he again forgot his wedding anniversary, right? Again, the wife is very angry with him and she again throws hot water at 4 p.m. Now she throws hot water at him at 4 p.m. and she locks him up in the bathroom till 6 p.m. Okay, so the poor guy only reaches the hospital at 6 p.m. My question is, what is the amount required? What is the amount required till midnight? How much fluid to give till midnight? So one thing which I want you to remember, that time will always be calculated. Time starts when patient gets burnt. Time starts when patient gets burnt, not when he comes to the hospital. So this is a very important concept which I want you to remember. You will start the time when the patient is getting burnt. So it will start at 4 p.m. rather than 6 p.m. Now 4 p.m. till midnight is how many hours? Correct, it is 8 hours. So 4 p.m. till midnight is 8 hours. So in 8 hours, we know half the amount is to be given. So half the amount will be 2 into body weight into total body surface area is our total formula. This divided by 2. So it is body weight into total body surface area, which is going to be how much? Which is going to be 60. And let's say this patient has 30% burns. So it is going to be 60 into 30. That will be the amount of fluid required in the first 8 hours following burns. Now, another thing which I want you to remember is that in children, it is slightly different. In children, we also have to give dextrose-containing maintenance fluids. We also have to give dextrose-containing maintenance fluids. This is not used in adults. Dextrose-containing maintenance fluids are only used in children. So how much is this maintenance fluid which is required? Maintenance fluid required is 100 ml per kg for first 10 kgs in 24 hours, right? For first 10 kgs, for first 10 kgs. Then it is 50 ml per kg in 24 hours for the next 10 kgs. And it is 20 ml per kg in 24 hours for every kg after 20 kgs. After 20 kgs. Right? So let's just calculate one sample calculation for you to understand how to calculate this value. So let's assume that the child is 22 kgs. So if the child is 22 kgs, for the first 10 kg, it will be 100 into 10, right? It will be 100 into 10, that is 1000 ml. Then for the next 10 kgs, it will be 50 into 10, that is 500 ml. And for the last 2 kgs, it will be 20 into 2, that is 40 ml. So this will turn out to be 1540 ml, which will be required additional in patients. This is the dextrose containing maintenance fluid which we'll need to use in children. Now there are other formulas also which you should know about. These are the ATLS formulae, right? So the ATLS guideline formulae for flames and scalds. So flame and scalds are second and third degree burns. So for adults who are more than age of 14, we already know the formula is 2 into body weight into total body surface area burned. For children less than 14 years of age, this formula is 3 into body weight into total body surface area burned. And for infants and young adults, I've already told you it is 3 into body weight plus we give sugar containing maintenance fluids. And I've already taught you how to calculate those sugar containing maintenance fluids. If it's a grade 4 injury, electrical burns, then in them it's the old Parkland's formula, which is 4 into body weight into total body surface area burned. Now we monitor whether adequate fluids are being given or not by the urine output. The minimum urine output which we want is 0.5 ml per kg per hour. In children, of course, we want a higher urine output of 1 ml per kg per hour. If there are electrical burns, you always have the risk of myoglobinuria. Right? So you want a higher urine output of at least 1 to 1.5 ml per kg per hour. And you will continue fluids till the urine becomes clear. The urine is not brownish, it becomes clear. Right? So these are the ATLS formulae which you should know about. In the latest edition of Sebastian, there are other formulas also which are given. Parkland's was given as 4, but I've told you the update. The update is now that Parkland's is 2 into body weight into total body surface area. Right, so this is the update. It has to be changed. It will be changed in the subsequent edition now. Brooks is 2 into body weight into total body surface area burned. And Galveston is a pediatric formula. These are all crystalloid formulas. So Galveston is 5000 cc per meter square burned plus 1500 cc per meter square for total body surface area. Right? This is the Galveston formula. You also have another formula for colloid resuscitation, and this formula for colloid resuscitation is known as the Muir and Barclay formula. This is given in Bailey. This is the Muir and Barclay formula, and this is 0.5 into total body surface area burned is equal to 1 portion. 0.5 into total body surface area burned is equal to 1 portion. And you will give 1 portion each every 4 hours for the first 12 hours, then every 6 hours for the next 12 hours, and every 12 hours after that, right? So this is how we calculate the Muir and Barclay formula, which is a colloid-based formula. But you remember I've told you that colloid should only be started after the first 12 hours because before this time, massive fluid shifts can occur. And that is why the vessels are leaky and we don't give colloids in the first 12 to 24 hours. The best answer will be first 12 hours we don't give colloids in patients. So these were the various burns resuscitation formulae which you should know about. They've been asked very frequently in exams, so you should be very clear about them. Now to calculate all these formulae, you need to know how to calculate total body surface area burnt. Right? Now, how do we calculate total body surface area burnt? So, total body surface area burnt, one crude method is that the palm is 1% total body surface area, right? Palm is 1% total body surface area. So this is a very crude method to calculate small areas of burns where we just draw the outline of the palm on a paper, cut that piece of paper, and we can just keep it on the area which has been burned and we can calculate how much burns are there. Of course, the most popularly used formula is the Wallace rule of 9. And you need to know that the Wallace rule of 9 is separate for adults and separate for children. If we talk about adults, in adults, head and neck, forms total of 9%. So 4.5 anteriorly, 4.5 this is front and this is back, 4.5 front, 4.5 back. Each upper limb is 9%. So 9 anterior, 9 back. Each upper limb is 9%. Each upper limb is 9%. So 4.5% front and 4.5% back. The chest and abdomen is 18 in the front and 18 in the back. Chest and abdomen is 18 in the front and the entire back is also 18%. Each lower limb is 18%. So 9 anterior and 9 posterior is for the lower limbs, and the perineum and genitalia is 1%. So this is the calculation of Wallace rule of 9 for adults. The Wallace rule of 9 for children is slightly different, and you should know the updates in children. In children, head and neck forms a larger proportion of body surface area. So as opposed to 9% in adults, it is 18% in children. So it will be 9 anterior and 9 posterior. So this is total of 18% for head and neck. The chest and abdomen and back is the same as adults. It is 18. Arm is also same as adults. So 4.5 anterior, 4.5 posterior. 9 has been taken from the lower limbs and been given to the head and neck. So the lower limbs combined will be 27%. So lower limbs will be 13.5% for each lower limb. And perineum and genitalia is again 1%. Perineum and genitalia is again 1%. You should also know that in infants, head and neck will form 21% body surface area and each lower limb is 13%. Each lower limb is 13%. So this is for infants. This is another update which has been mentioned in the latest Sebastian. You should also know that there is a Burko formula, and the Burko formula is specific for children. This is a formula which is used in children, or charts which are used in children to calculate total body surface area burned. One more are the Lund and Browder charts. These are the Lund and Browder charts, and the Lund and Browder charts are the best method to calculate total body surface area burned. This is the best method to calculate total body surface area burned. These are the Lund and Browder charts. Okay. Usually we don't use them for calculation, but if you want an accurate calculation, you will use the Lund and Browder charts. Now for your exams, you just need to know the Wallace rule of 9. Majority of the questions can be answered using Wallace rule of 9. Up till now, in last 6-7 years, there's just been one question from Lund and Browder, and that was actually in the NIMHANS exam 3 years back, right? So other than that, all questions have been based on the Wallace rule of 9. Now, this was a image which was shared to me by a friend who's doing MCH in plastic surgery at Safdarjung Hospital. Safdarjung Hospital has one of the best burns unit in the entire country. So in this child, we have this entire right upper limb is burned and the entire chest and abdomen is burned, right? So you have to calculate the total body surface area burnt in this child. Of course, there are some sporadic burns in the face as well. We are going to ignore them. So what will be the total body surface area? So right upper limb in this would be 9%, front and back 4.5, 4.5. And here we have the chest and abdomen. Here we have chest and abdomen is 18%. So 27% is the total body surface area burned in this child. Okay, in this child. So you can be asked such questions as well, where you can be shown an image and you can be asked to calculate the total body surface area burnt. So up till now, what we've discussed is how much fluid to give, how to calculate the total body surface area burned. The third question which we need to ask is about the actual burnt area. How severe is the actual burnt area, right? So one of the classifications is the other zones of burns. And the zones of burns divides the burnt area into zone of coagulation or necrosis, zone of stasis, and zone of hyperemia, right? So you can see here that the zone of coagulation is the most severely burnt area. The zone of coagulation or necrosis is the most severely burnt area It is the most severely burnt area, and there is irreversible injury here. And there is irreversible injury in this zone. This tissue cannot be salvaged. The zone of hyperemia, which is the outermost, the zone of hyperemia is the outermost. There is vasodilation here, which is why there is hyperemia, and this usually recovers. This usually recovers. Now, the most important zone is this zone of stasis, which is in between, right? The zone of stasis is in between, and this zone of stasis has reversible injury. This has reversible injury, right? So the advantage of the zone of stasis which has reversible injury is that if proper management is done, and if proper care of the wound is taken, then it recovers. It will go into the zone of hyperemia and it will recover. But if infection sets in, then it can land up into the zone of necrosis. Then we can lose this tissue and it can go into the zone of necrosis and we lose that tissue. So these are the three zones in burns which you should know about. Now moving on to based on the depth, what are the various degrees of burns which are there based on the depth of burns, right? So based on the depth, you can have first degree, second degree, third degree and fourth degree burns. So first degree burns are the burns which only involve the epidermis. They only involve epidermis. The burnt area is red and extremely tender. The burnt area is red and extremely tender. But a unique feature about this burnt area is that there's complete blanching. There is complete blanching. Right? Blanching means that the area is red, but when I press it, it becomes white. And as soon as I leave it, it becomes red again. So there is complete blanching which is seen. And another peculiar thing about first degree burns is that they heal without scarring. In 3 to 5 days. They heal without scarring in 3 to 5 days. So whether you put any dressing material on them or not, they will heal without scarring in 3 to 5 days. And the prime example of a first degree burn is a sunburn, right? So if you go on a trip to Goa with your friends and you spend a lot of time on the beach and you don't apply sunscreen, you can get a sunburn. And these sunburns are extremely painful. They're red. But in 3 to 5 days, they heal spontaneously without scarring. So they won't leave a scar behind. All they leave behind is happy memories which you spent with your friends in Goa. So definitely plan that trip when your exams get over. Second degree burns can be divided into second degree superficial and second degree deep. So second degree burns can be second degree superficial burns or they can be second degree deep burns. So second degree superficial burns involve the epidermis plus the papillary dermis. Second degree deep burns involve the entire epidermis plus the dermis. That means papillary and reticular dermis. So second degree superficial burns are very much like first degree burns. They are red, they are tender, they blanch. Blanching is present in them. And they also heal without scarring in 2 to 3 weeks. They heal without scarring in 2 to 3 weeks. But a peculiar feature of second degree superficial burns, which has been asked multiple times in the exam, is the presence of a blister. So blister formation is seen in second degree superficial burns. And I'm sure all of us during our lifetime have either spilled hot milk or hot water on our hands, or we've touched a hot iron. And after some time, we notice a blister there. So that blister is a telltale sign of a second degree superficial burn. And you can see in this image as well, you can see this blister which is there. This blister represents a second degree superficial burn. And one thing which you should remember, that we should never burst these blisters. Don't burst these blisters because they're extremely painful, and then there can also be infection. So don't burst these blisters if you get a patient in the emergency. Second degree deep burns. Second degree deep burns are also red. They are less tender. They are less tender as compared to second degree superficial burns. And entire area does not blanch. There are some areas of fixed staining. There are some areas of fixed staining. That means when you press it, the entire area will not blanch. Some area will have thrombosis of the vessels, and that area will not branch. There will be fixed staining there. Okay, so that is the difference between second degree superficial and deep. Blister formation is also less common. Blister formation is also less common. And second degree deep burns have a tendency, to form hypertrophic scars and keloids, right? They have a tendency to form hypertrophic scars and keloids. That is why the second degree deep burns have to be managed properly, right? They have to be managed properly. Okay. Now I just want to show you an image. This was a patient who had sustained burns on the hand, and I want to show you serial images of how the healing takes place, right? So these images were again shared by an MCH resident in Safdarjung Hospital, and he had taken serial pictures. So this was the initial area of burns, and you can see here that this patient had blisters, and the burned area was second degree deep burns. There were some areas of third degree burns as well, which I'll talk about in some time. So this patient, proper dressings were done, proper debridement was done, and regular dressings were done. You can see this was after the debridement and the dressings. After a few days, the skin has started peeling off, and you can see redness appearing. Then this is after a few weeks. You can see the epithelium has started coming back again. Of course, there is depigmentation which will persist for some time, which does persist for some time. Now, this was another patient who had second degree and third degree burns, and you can see that the patient developed hypertrophic scars and keloids following the burns, right? So hypertrophic scars and keloids were there following the burn management. So this can occur specifically after second degree deep burns. Now you can have third and fourth degree burns as well. Third and fourth degree burns. So third degree burns go up till the subcutaneous tissue, whereas fourth degree burns go up till the muscle layer. They go up till the muscle layer. Now the features of third and fourth degree burns are that these burnt areas appear black and charred, right? They appear black and charred. So you can see in the image the area appears black and charred. It is absolutely painless. It is absolutely painless. And I want to share one experience here with you. This I mentioned in other modules as well, that we were final year residents, we were final year undergraduate students when a bomb blast occurred in Sarojini Nagar. Sarojini Nagar was a popular shopping area close to Safdarjung. And, you know, we also went to the burns unit to help out because there were so many patients who were coming in. And, you know, at that time we were surprised. We'd always read that third and fourth degree burns are painless. And we saw a couple of patients who had extensive third and fourth degree burns, but they weren't even wincing. I mean, we were doing the dressings, we were, wrapping that area up, but they did not have any sensation. In fact, sensation was more in those areas where there were less degrees of burns. So these are absolutely painless because the nerve endings get burnt, right? And you can even stick a needle there and they will not have pain. Now, there is fixed staining. There is fixed staining. That means there is no blanching. It does not blanch. Even if I press it, it remains black. It does not become white. The management of third and fourth degree burns is early excision, followed by split thickness skin grafting. So they will not heal on their own. You have to excise that area and carry out split thickness skin grafting in these patients. right? That is the only way you can manage third and fourth degree burns. So early excision followed by split thickness skin grafting. And if you remember the module on plastic surgery, I've already told you about skin grafting. And I also told you that there are burns units which have skin banks associated with them, right? Because majority of the skin supply is required for these burns patients. So there are skin banks where we can save the split thickness skin grafts for 2 to 3 weeks at 4 degrees centigrade, and we can utilize them in these third and fourth degree burn patients. So these were the burns based on the depth of burns. So now what we've discussed is the initial airway burns. How does it present? We've spoken about resuscitation in burns patients. We've spoken about how to calculate the total body surface area and how to calculate the depth of burns. Let's now focus our attention on the actual management of a burns patient. So let's talk about burns management. Now, whenever a burns patient comes to the emergency, I've already told you about ABCD. In addition to that, local care also has to be provided to that burned area. Now, whenever we get a burns patient, the first thing is to wash that burned area with room temperature water. And this should ideally be done within 3 to 4 hours. And this can actually reduce the area which gets injured. So the amount of injured area can reduce with this. Also, we should remember that the water should not be very cold, because if the water is very cold, we can induce hypothermia in these patients. So room temperature water is what is recommended. I've already told you, don't burst the blisters because they're extremely painful and they can predispose to infections. IV fluids have to be given in these patients. We've already discussed the fluid resuscitation formulas. Another very important thing mentioned both in Bailey and in the latest Sebastian is that IM and subcutaneous injection should be avoided in these patients because there is altered absorption. There will be some areas where there is vasodilation and there'll be some areas where there's vasoconstriction. So there'll be altered absorption here, which is why we don't use IM and subcutaneous injections in these patients. One more thing which you need to remember, that any person with greater than 15 to 20% total body surface area burns, anyone with more than 15 to 20% total body surface area burns, there is a likelihood of gastric distension and ileus. There is a likelihood of gastric distension and ileus in these patients. And in these patients, we should insert a nasogastric tube. And this nasogastric tube helps in decompression and also helps in the nutrition of these patients. The next major thing in these patients is nutrition. We know that whenever there are burns, it is a negative nitrogen balance state, right? The body is losing nitrogen, body is losing proteins. So adequate nutrition is of paramount importance in healing of these patients. I've already discussed in the chapter on nutrition that in a normal person, the basal energy expenditure or the resting energy expenditure is 1. That means 20 kilocalories per kg per day is required. But if there is mild to moderate sepsis, the caloric requirement goes up. It goes to 1.4 times. In severe sepsis, it becomes 1.8, whereas in patients with severe burns, it becomes 2 times the normal basal resting value. That means 40 kilocalories per kg per day. And I've already told you that of more than 15% burns, we should insert a Ryle's tube for feeding in these patients. Now, another very important thing which you should remember here is that because it is a negative nitrogen balance, a high protein diet needs to be given. And the maximum nitrogen loss occurs between day 5 to day 10. And it is during this period that at least 20% of all calories should come from proteins. So you need to give a high protein diet to these patients. Now, how do we calculate how much protein is required in a burns patient? So there are various formulas which are there. There are various formulae. And I've already told you that the protein needs, the greatest needs are between 5 to 10 days, and 20% of all kilocalories should come from proteins. And to calculate this, the most commonly used formula is the Davies formula. The Davies formula in children is 3 grams per kg plus 1 gram into total body surface area burned, whereas in adults it is 1 gram per kg plus 3 into total body surface area burned. So don't get confused. The values are slightly confusing. You should have clarity regarding the formula. The Cureri and the Sutherland formulas are used to calculate the caloric requirements in burns patients. Even if you don't remember these formulas, they're all right, but you should know Cureri and Sutherland's are to calculate the caloric requirement, whereas Davies tells us the protein requirement in patients with burns. The next thing which you need to remember is that these patients can also have eschar. So we've discussed eschars are thick. Eschar is thickened tissue after burns. Eschar is thickened tissue after burns, that is eschar. And this thickened tissue, if it is present around the chest, it can give rise to respiratory compromise. And if there is thickened tissue which is present in a circumferential manner, around the limb, then it can give rise to compartment syndrome. We've spoken about compartment syndrome at various places, and you know that if you have a thickened tissue around the limb, right, supposing an electrician is there and a wire wraps around his hand and he has burns all around the limb, this can give rise to compartment syndrome. And compartment syndrome will occur when the compartment pressure is more than 30 millimeters of mercury. How will the patient present? The patient will have excruciating pain, which is not getting relieved by medicines. So that will be the typical history, that the patient will have pain not getting relieved by medicines, and pain increases on passive stretching. Right? So if compartment syndrome we are anticipating, then we have to cut this eschar, and that is known as an escharotomy. And escharotomy is similar to a fasciotomy. And while we are doing this escharotomy, we are going to cut through skin, subcutaneous tissue, superficial fascia, and we incise the deep fascia as well. So we cut right up till the deep fascia and the muscle should pop out. That is an adequate escharotomy or a fasciotomy in such patients. There are certain points which I want you to know which have been written in both Bailey and Sebastian regarding escharotomy. So upper limb, the incision should be a mid-axial incision anterior to the elbow to avoid injury to the ulnar nerve. That is important. So the incision should be anterior to the elbow. In the hand, midline in the digits, and we should relax the muscle compartments. This is very important. It should be done in the theater with an experienced surgeon. Why the theater? Because there can be a lot of bleeding when you're doing an escharotomy as well. Lower limb, it should be mid-axial, and we should be posterior to the ankle medially to avoid the saphenous vein. Very important is for the chest. In the chest, you go transversely from below the clavicle, then on the side of the nipples, and again transversely or laterally at the lower part of the chest. That is how a fasciotomy is done. So down the chest, lateral to the nipples, across the chest, below the clavicle, and across the chest at the level of the xiphisternum, right? The general rules are we should go beyond the burn, diathermy vessels because there can be bleeding, and hemostasis should be ensured, right? So these are the basic principles of escharotomy which we should know in these patients. Another major aspect in the management of burns wounds is the actual dressing, and you should know about the dressing materials which are used in burns. Now, the principles of dressings in burns patients, and this is written in the latest Sebastian, are to protect damaged epithelium, to minimize bacterial or fungal contamination, and the dressing should be occlusive so that it prevents evaporation and fluid loss. If you have first degree burns we've already discussed, like sunburns, you don't need to do anything in them. You just need to expose those wounds. Nothing else is required. Second degree burns, second degree superficial, where you have a blister as well. You don't burst the blister. Don't burst the blister. Just Vaseline or paraffin gauze is to be used so that it keeps that area moist. I'm sure as interns, all of you have seen Vaseline gauze. It is this fenestrated gauze which has Vaseline or paraffin on it. So it's very moist, and you can put it over an area. It won't get stuck there. It doesn't get stuck there. We can even use collagen dressings. Collagen dressings are only used if the wound is non-infected. If there are second degree deep burns, then we can use collagen dressings or hydrocolloid dressings. Both of them I've covered in the module on plastic surgery and wound healing. And one of the hydrocolloid dressings is known as Duoderm. For third and fourth degree burns, I've already told you we have to excise that burnt area and do a split thickness skin grafting. Now for second degree burns, that means second degree superficial and deep burns, we use special dressing agents as well. And these dressing agents are used so that they can hasten the healing process, and they can also prevent infection. So these special agents are silver sulfadiazine. This is the most commonly used special agent which is there. It requires frequent change of dressing, but it has good action against Pseudomonas, which is the most common organism responsible for infection in burns patients. Right? This I'll cover later as well, that Pseudomonas is the most common organism responsible for infections in burns patients. It also has good action against gram-negative bacteria. The problem with silver sulfadiazine, it does not penetrate the eschar. So it remains superficially. It cannot go into the deeper layers. Silver nitrate is another substitute which can be used. It has good action against Pseudomonas, but little action against gram-negative bacteria. And it stains everything black. The problem is frequent change of dressing is required. And it stains everything. It stains everything black. By everything, I mean the furniture, the dressing, everything is stained black when we use silver nitrate. Another special agent is mafenide acetate. Mafenide acetate is frequently used in America. Mafenide acetate penetrates the eschar. So this is going to penetrate the eschar and it can go into the deeper layers. But the problem with mafenide acetate is that painful application, very painful application is there. And it can induce metabolic acidosis. This has been asked in the exam. It can induce metabolic acidosis in patients. So you should know about this as well. Cerium nitrate is the best agent which is available. And this cerium nitrate has an immunomodulatory effect. It has an immunomodulatory effect. That means it helps in healing and also prevents wound infections. So you should know briefly about these dressing materials as well. Now, as the burns wound heal, like I showed you those serial images of the hand healing up after burns, patients can develop contractures as well. And when they develop contractures, we need to release these contractures. So management, we need to carry out surgery to release these contractures, and we can either do a VY-plasty or a Z-plasty. Both of them are local flaps, which I've covered in the plastic surgery module, and you can refer to that plastic surgery module for details. And those flaps can be done here to release these contractures which can develop following burns. A very common question which is asked in the exam are the causes of death following burns. And these have been asked frequently. The most commonly asked is immediate, which is asphyxia more than neurogenic shock. Early is in 1 to 3 days, it is hypovolemic shock. After 3 days, it is septic shock. And overall, also it is septic shock. So these 4 one-liners you should know for your exam. You should also know the most common organism responsible. The most common organism which infects burns wounds is Pseudomonas. This must have been covered in great detail by Dr. Shivika. And for us surgeons, we get to know there's Pseudomonas if the dressing becomes green, because you know this Pseudomonas has certain compounds which it releases. So the pus becomes green in color, right? And that is what we look out for. And if we notice that it is becoming green, we know that the patient is probably developing a Pseudomonas infection. You should also know that there is a global decline in immune function. There is a global decline in immune function following burns. And this can predispose the patient to infection. This can predispose to infection. And this decline is directly proportional. This decline is directly proportional to the extent of burns. It is directly proportional to the extent of burns which are there. Now, before I talk about the special situations related to burns, these special situations yield a lot of questions. I just wanted to share an image with you which I clicked during the monsoon season. This was from my apartment. I clicked this lightning picture. And why I'm showing this is because one of the special situations which we're going to talk about in burns is lightning injury. So I just wanted to start off that topic by showing you this image. So the special situation, number one, is circumferential burns. In circumferential burns, I've already told you about Eschar's. I've already told you about Eschar. I have told you about compartment syndrome. And I've told you that Escharotomy is required in these patients. So that was special situation number one, which you should know for your exam. Special situation number two is acid or alkali burns. Acid or alkali burns. So the points which you need to know in acid and alkali burns are that whenever you get such a patient, never try neutralization, okay? Never try neutralization. Now, neutralization is something which we've all read in school in chemistry, that if you have an acid, you can neutralize it with an alkali as well. But we've also read in chemistry that this is an exothermic reaction. So if supposing there is acid burns and if I pour alkali over it, I might neutralize that area, but when heat is produced, that can extend the area of burns, right? So we never try neutralization. We should wash with water. Wash with water, right? Except elemental sodium and phosphorus. If it is elemental sodium and phosphorus, we don't wash with water because it can react with that. This has been mentioned in the latest Sebastian. You should know that if it is due to powder, if it is due to a chemical powder, we just brush it off. Just brush it off. Again, when it's due to a chemical powder, we don't use water over it. The rest of the principles for acid and alkali burns management are similar to the burns management principles which I've just told you. One special acid burn which requires mention is hydrofluoric acid burns. So hydrofluoric acid burns is very important for the exam. This was a pet favorite of the JIPMER exam and it has been asked in the INI CET exam as well. So hydrofluoric acid burns, what this does is that this can chelate the calcium. This can chelate calcium and it can give rise to hypocalcemia. There can be hypocalcemia. There can be hyperkalemia. And this hypocalcemia and hyperkalemia can predispose the patient to arrhythmias as well. Can predispose the patient to arrhythmias, which is one of the leading causes of death in patients with hydrofluoric acid burns. So what exactly is done in these patients? You should also know that they're extremely painful, right? So the management of hydrofluoric acid burns, if it is a small area, of burns, then we will apply calcium gluconate. Then we are going to apply calcium gluconate gel. Then calcium gluconate gel is going to be put. If it is a moderate area where the patient is not responding to topical treatment, then IV calcium gluconate can be used. IV calcium gluconate plus oral. And if it's a large area, then IV plus intra-arterial can also be used. This question has also been asked in the exam. Intra-arterial calcium gluconate can also be used in patients. So that is the management of hydrofluoric acid burns, which you should know for your exam. The third special situation which you should know about are electrical burns. Now, electrical burns can either be due to alternating current or can be due to DC current. So, alternating current is the current which is present in all the sockets in our house, that is AC current, and DC current is direct current. So, some basic principles which you should know about electrical burns, and then I will tell you the specific features about AC and DC burns. So, electrical burns are usually high degree burns. These are usually high degree burns. These are usually third and fourth degree burns which are there. And you always have an entry burn where the current comes in and an exit burn. So you should always look for the exit burn as well. A lot of times this is missed out. And I will tell you an instance where we had a first year postgraduate who was posted in the plastic surgery unit, and there was a patient who would come with electrical burns. He just dressed the burn in the hand, but he missed out the burn in the leg, which subsequently became infected. So you should always search for the exit burn as well in these patients. And you should know that the most common cause of death is arrhythmia. So as the current travels through the body, it can induce arrhythmias. And these arrhythmias are common in the first 24 hours after burns. These are most common in the first 24 hours. This is what is written in the latest Sebastian as well, and it has been asked in the exam. Also, you should know that muscle injury, muscle is the structure. Muscle injury is very common. Muscle injury is very common, and that is why there can be myoglobinuria as well. There can be myoglobinuria in these patients. And because of this myoglobinuria, the urine will be brownish, and it can also induce renal failure, which is why in patients with electrical burns where there is myoglobinuria, there should be aggressive fluid therapy. And if you remember, I told you in electrical burns, we follow the old Parkland's formula, which is 4 into body weight into total body surface area burned, right? So these were some basic things which you need to know regarding electrical burns. AC burns, alternating current burns, and DC burns. DC burns induce heart block. DC burns can cause a heart block, so this is the thing which you should know. And AC burns, alternating current burns, another thing which you should know, that they can cause tetany, right? Tetany means repetitive muscle contraction. And the easiest way to remember this, I'm sure all of you have seen this television ad of these electrical wires where this person presses the doorbell and she gets a shock and all her hair stand up. The shock laga laga ad, right? The famous shock laga laga ad. So where she just presses the bell button and her hand just keeps on shaking there and the hair stand up. Now, the reason why the hand is shaking there is because of tetany. So repetitive muscle contraction, because of this, tetany is induced and it becomes difficult for them to withdraw their hand. Right? So because of tetany, they can't withdraw their hand. And this tetany can also lead to muscle injury, which can lead to myoglobinuria. And AC current can also induce arrhythmias, which I've already told you are the most common cause of death in electrical burns. Now, the final special situation which I want you to know for the exam is lightning injury. So I already showed you the image of lightning. And lightning injury can be of two types. It can either be direct lightning injury or it can be indirect lightning injury. Both have been asked in the exam. Direct lightning injury is when the lightning directly strikes the person. And there was a school friend of mine. He and his wife had gone to Goa 3 years back. and they were sitting on the beach, and in the night, lightning directly struck them. My friend unfortunately passed away on the spot, and his wife also suffered from arrhythmias, and she also succumbed to those arrhythmias later on. So it is a serious problem wherever lightning strikes the ground. These injuries can occur, and again, direct lightning injury is like a high grade electrical injury, is like a high grade electrical burn, where again you can have entry and exit burn, and arrhythmias are common, and these are the leading cause of death in these patients. So it's like a high voltage electrical burn. The one which has been asked in the exam is indirect lightning injury. And to understand indirect lightning injury, I just want you to understand that supposing there are two teams which are playing football in the rainy season. Like, you can't play cricket when it's raining, right? So a lot of teams, they start playing football during those times. And there are two teams which are playing football, and it's the monsoon season. The goalkeeper is standing on his goalpost, and this lightning strikes the metallic goalpost. When it strikes the metallic goalpost, sparks are given off, sparks fly off. And when these sparks fly off, they burn the goalkeeper. So this is indirect electrical injury, right? Where lightning strikes an object, where lightning strikes metallic object, and sparks are given off. And when sparks are given off, they cause superficial burns. They cause superficial burns in exposed areas, and the pattern which you get, this is known as filigree burns. This question has been asked 2 or 3 times in the exam, and it's been covered in forensic as well. This pattern of superficial burns is known as filigree burns, which can occur after lightning injury. So these were the special situations which I wanted you to know. So let's now talk about hypothermia. Hypothermia is when the core body temperature is below the normal value, and it usually takes 30 minutes of cold exposure. It usually takes 30 minutes of cold exposure in a normal patient, in a normal person, to induce hypothermia. But if you have a child or an elderly patient, much less time would be required to carry out hypothermia. Now, there are various stages of hypothermia which you should know about. Stage 1 hypothermia is the stage of conscious shivering, and shivering is being done to generate more heat, and here the temperature is between 35 to 32 degrees centigrade. And here what is required is a warm environment and clothing, warm sweet drinks, and active movement. So basically here we are doing passive rewarming. Now there are two types of rewarming techniques which I'll tell you about. One is passive rewarming and one is active rewarming. Passive rewarming is where we are preventing the loss of heat from the body. And how do we do that? We dry up the patient, we put blankets, we put a cap. So we want to prevent heat loss. Whereas active rewarming techniques are where we are heating up, where we are trying to increase the core temperature by giving warm fluids, by putting in a heater. All those things are adding to the temperature. Okay. So for stage 1, only passive rewarming techniques are enough. Stage 2 is impaired consciousness, not shivering. Patient is not shivering now because of hypothermia. Here it is between 32 to 28 degrees. And here we have to carry out cardiac monitoring because these patients can have arrhythmias as well. And they can be J waves which can be seen. J waves or Osborne waves can be seen here, which are seen in hypothermia. And cautious movements to avoid arrhythmias. There should be active rewarming done as well. So from grade 2, active rewarming techniques along with passive techniques should be done. 3 is when the patient is unconscious and no vital signs are present. No shivering is also there. This is between 28 to 24 degrees. And here the treatment is like stage 2, plus we put the patient on ECMO. ECMO, you know, is extracorporeal membrane oxygenation. ECMO is extracorporeal membrane oxygenation, or we put the patient on a cardiopulmonary bypass machine. Finally, you have a patient with no vital signs. Here it's less than 24 degrees. And here we have to do CPR for these patients, give adrenaline. Now, one thing which you should remember is we never declare these patients, never declare patients dead till they are warm. Right? So these patients with hypothermia, you will only declare them when they are warm and dead, not when they are cold and dead, right? So when there's hypothermia, the patient can have minimal activity or minimal body vital signs can be there. But as you heat up the patient, a lot of them might recover. So please don't declare them dead. Even if they don't respond to adrenaline, don't declare them dead till they are warm and dead. That is the take-home message which you should remember. Now, rewarming techniques, I told you, you can either have passive rewarming or active rewarming. Passive rewarming is when we are preventing heat loss, and this can be done by drying the patient by warm environment, shivering, blankets or clothing, and to cover the head. And this is mainly done for mild hypothermia. Active rewarming techniques can be divided into external and internal, and these are basically when we are actively trying to heat up the patient. External can be heating pads, warm water immersion, heaters, right? These are done for mild and moderate hypothermia. Internal techniques are warm fluids, gastric lavage, warm inhalation, mediastinal lavage, and this is done for moderate and severe. And finally, you have extracorporeal rewarming, which is in the form of cardiopulmonary bypass. And cardiopulmonary bypass is the most effective way. This is the most effective method to rewarm a patient. This was asked in the super specialty exam. This is the most effective method to rewarm the patient, that is cardiopulmonary bypass. That has been written in the latest Sebastian as well. So most effective method to rewarm the patient is cardiopulmonary bypass. Two more problems which are associated with cold environment are frostbite and trench foot. Frostbite is when ice crystals are formed in the tissue and they can cause membrane injury and microvascular damage. So these ice crystals can cause membrane injury. And also when you rewarm these ice crystals, there can be reperfusion injury. So it's a double whammy. First, these ice crystals cause membrane damage, and then the rewarming can cause reperfusion injury by generation of more free radicals. There are 4 stages of frostbite. You have hyperemia. Stage 2 is when there is large vesicular loss. Stage 3 is when there are hemorrhagic vesicles, there's full thickness skin loss. And stage 4 is when muscle or bone are involved. So these are the 4 stages of frostbite. Let me tell you about trench foot as well, and then I'll tell you the management of both frostbite and trench foot. Trench foot is when there's exposure to cold, but the limb is also wet. So tissue is wet and there is exposure to cold. That is what gives rise to trench foot. There is microvascular damage and there's stasis and occlusion. There can also be gangrene in patients with trench foot. The management in these patients is gradual rewarming of the leg, and water should be at 40 degrees. There are certain books which say that rapid rewarming should be done, but what we will follow is gradual rewarming. We don't rub the tissue. It's extremely painful. We have to be aware of perfusion injury, and there can be hyperkalemia and acidosis. So one should be aware of these points as well. And if there is gangrene, then we should wait for the demarcation line before we amputate. So these were the points in thermal injury. Of course, the more important topic is burns, but I've also covered about hypothermia. One thing which I want you to know in hypothermia, which is very important for your exam, and this has been asked in the AIMS and the INI-CET exam as well, that in hypothermia, the best method to record temperature in a hypothermic patient is rectal temperature. So rectal temperature or esophageal temperature, and if you have to choose one, you will mark rectal temperature is the best method to measure the temperature in these patients. This was asked in the INI-CET exam, where they had asked that a soldier from Siachen is brought in with hypothermia. How do we assess the temperature? Now, before we discuss MCQs, what are the topics which are important for final year students? So, burns comes as a long question in your university exam. So, each aspect is very important. Burns resuscitation is very important. This comes as a short note. Parkland's formula comes as a short note. And the types of burns or the degrees of burns, the types and the degrees of burns also comes as a short note. So these are the things which final year students should prepare. Let's talk about certain MCQs before we end this topic. And before I start discussing the MCQs, another picture of a sunset which I clicked when I was doing my fellowship in America. This was in Baltimore where I was doing my fellowship, and the sky was so fiery red. It literally represented as if the sky is burning, right? But it was a beautiful sight, and I just tried to capture it through my lens. So some questions: which of the following patients doesn't meet the criteria for referral to a designated burn center? So 5% full thickness burns, this person will go to the burn center. 50-year-old with singed nasal hair means there are airway burns, they will go. Partial thickness burns involving the right upper limb. So right upper limb would just be 9%. This does not classify. It has to be more than 10%. Electrical burns involving hand and leg. This is correct. I've already told you these criteria. Which of the following are danger signs suggestive of airway burns? I told you burnt or singed nasal hair, hoarseness of voice, burns in a closed room, burns involving chest, no, face and neck, yes. Blackish deposits in sputum, yes. So A, B, C and E is the correct answer. A, B, C and E is the correct answer here. Which of the following statement regarding zones of burns is not true? Zone of hyperemia is the least affected and it usually recovers. This is absolutely correct. Zone of coagulation or necrosis shows irreversible injury. This is true. And zone of stasis progresses to zone of coagulation if infection occurs. This is also true. And tissue in zone of stasis is associated with thrombosis of vessels. This is also true. So all the statements are true here. None of the statements are false. Sometimes that can also happen. This question I've already told you about the man who got burnt, and I've told you how to calculate the requirement in these patients. Which of the following statements is not true regarding circumferential burns? This was a neat super specialty question which I want to cover because sometimes these questions are asked in the PG exam as well. Escherotomy should be done in patients with circumferential burns and it can lead to significant weight loss. This is correct. This should be carried out if the compartment pressure is more than 30. Yes, this also I've told you. Escherotomy involving the chest should be done lateral to the nipples and across the chest below the clavicle and the chest at the level of xiphisternum. This is true. Escherotomy involving the chest should be done lateral to the nipples and across the chest at the level of xiphisternum alone. No. So one across below the clavicle and one across below the xiphisternum. A burns patient suffers 25% full thickness burns. Which of the following statements regarding the nutritional requirement of this patient is true? Davies' formula for protein requirement is in adults is 3 grams per kg. Is 3 grams per kg plus 1 gram into total body surface area? No, this is for children. This is false. At least 20% of kilocalories should be provided by proteins during the maximum phase of Newton's law, this is true. Nasogastric tube should be used in all patients with burns over 10%. This is false. It should be more than 15 to 20%. And modified Bohr formula is used to calculate caloric requirement. This is false. Modified Bohr formula tells us the mortality, the risk of mortality following burns. And the most important factor which determines mortality, the most important factor which determines mortality is the presence of inhalational injury. Is the presence of inhalational injury. This is the one which determines, which is the most important factor which determines mortality in burns patients. It is not the age, it is the presence of inhalational injury which is the most important factor. Which of the following statements is true regarding chemical burns? Chemical burns caused by dry powder should be washed? No, they should just be brushed aside. Alkali burns are more superficial as compared to acid. This is false. Alkali burns are more deep. They are more deep. They penetrate deeper. Calcium gluconate is used for hydrofluoric acid burns. This is true. Water lavage is useful in all liquid burns, including phosphorus and elemental sodium. False. These we don't do water lavage. So these were some questions regarding this module. This is a very important module, so please do revise this module before your exams. Thank you.